Welcome to Let's Talk About Health, an informational podcast that gives you insights on health and fitness from experts themselves that you can apply directly to your own personal health and fitness stories. Come join me today to hear all about what they have to say on health and fitness. Yeah. So thank you so much. Let me start by thanking you. I know we've been going back and forth a lot. We've been trying since a long time, but here we are. I'm so happy that you chose to speak with me today and on this platform. And we'll be discussing more because I love your work. And it's something that's very unique. Not everyone talks about it so often.
That's fair. Yeah. It's kind of its own little niche.
Yeah, but we'll be talking more in depth about it. So let me start by asking you, what do you think, or what's your definition of health and fitness?
Oh, health and fitness. Oh, this is going a totally different direction than I was thinking. No, that's okay. I'm joking. Health and fitness. Oh, man. Health. Being healthy. There you go. I don't know. I can't use the word in the definition, can I? Your body functioning as it should in a way that you would like it to without too many negative side effects. That's how I would define health, I guess, from a functional perspective.
I love it. Let's dive in. I love the impromptu definition of health. I've never heard that one though.
Yeah, definitely caught me off guard, but yeah, that's the best I can do, I guess.
I love it. Okay, so you are a swallow specialist and a dysphagia, what do you call it, therapist or specialist?
Yeah, no, it's interesting. So there is a BCSS, it's board certification of swallowing specialists, and there are benefits to it, but it's not like it is in medicine. So medically focused speech pathology is speech pathology is very broad. There are 9 diagnostic categories, and really, as it is, our education doesn't provide us with enough foundation to go out and do all those things proficiently, in my opinion. So I really focus and specialize on patients with swallowing disorders. And I pursued an additional degree beyond the initial one, and a whole lot of continuing education in that. And that's really my focus and my passion. I've loved it for a long time, and it's definitely what I'm passionate about. Whether or not you call me a specialist, that's up for debate. I don't know. It depends.
I love that you're being so humble about your education. Like, you have double degree, and that's a lot. That's really a lot. Tell me a little bit more about swallow pathology and dysphagia.
Well, it's a lot more than people recognize. And so, I mean, you don't really think about it. It's something invisible that you don't see. Like you take a drink of water, like I'll do now and try not to aspirate. But you do that. All right. If anyone's watching, I'd say, like, do the same thing. Try to swallow something. It takes about a second to a second and a half from the time that you volitionally do it in your mouth. But there are, 30-ish muscles and muscle pairs, 5 main cranial nerves with the input of a 6th and debatably a 7th, cervical spinal nerves, all that work together to coordinate in a very precise fashion, not just to move stuff from your mouth to down your throat, but to protect your airway, because you think of it as like your airway is kind of like an upside down Y. And I knew I had this notebook for a reason. And this is a very big oversimplification, but if you think of that,
right.
So like one path is always closed off. So there you go. This side, I can't even see. This side's always closed off. That's where the food and liquid would come up. And because you always have to breathe. Like you have to breathe, you hold your breath for more than a few seconds, and it's like, oh, that hurts. But so like it's very important when you swallow that your airway closes off completely, and that your food path opens. You don't want this, again, back to this why, like you don't want your food pipe open, your esophagus. So it goes esophagus, throat, and then mouth. If your esophagus is open at the top, you'll have acid reflux come up, and it can get in your vocal cords. It hurts. It doesn't feel good. It doesn't taste good. And so that has to open just temporarily when you swallow and your airway closes, because if your airway doesn't close sufficiently, you could get food or liquid into your lungs and can cause your asphyxiate, pneumonia, pulmonary edema, a number of different things. And so the process is a lot more complicated than people realize. And that's kind of what fascinates me about it. If anyone, has a few minutes of free time, I'd say after this, go on YouTube and type in the word modified barium swallow study, modified barium swallow study. Try to find like a typical one and then an atypical one. And it happens real fast, but look out mechanically what's going on. And there's another one you could look up, flexible endoscopic evaluation of swallowing fees. And that's really from like an endoscopic perspective if you're looking in. But, as you can tell, I'm passionate about it. And I could tangent and talk for a long time, but it's a lot more than you think.
Right.
And so I think it's fascinating, and it has a heavy impact on patients. And there are a lot of gaps in education. So that's one big reason why I'm pursuing what I am right now.
Mm-hmm. I remember watching when I was doing my pre-med schooling, the biology classes.
Mm-hmm.
We saw videos. So when we were watching videos about the anatomy, I remember the epiglottis and the glottis, the functioning, and it's so quick, like you mentioned.
Mm-hmm.
It just takes a few seconds because you can't stop breathing for longer, and your food takes time to go through the esophagus downwards. So yeah, it's so fascinating that small pipe can cause so much, like coughing, hiccups, so many things that you also deal with breathing disorders or digestive disorders to some extent?
So, sort of where it gets tricky is, so there are three, I mean, technically four, but there are three primary stages to the swallow. There's the stage that involves the mouth, the oral prep, and the oral phase, and the pharyngeal phase that involves the throat, and that's where the laryngeal valving for airway protection with the epiglottis and some other things occurs. And then the third stage is the last stage is the esophageal stage. Mm-hmm. And at that point, that's considered to be outside of my scope of practice. You would be with a GI doctor for that. And that involves peristalsis. And it's kind of a simpler process than everything else that's going on. But so with airway, there is a lot to do with breath swallow coordination, the synergy and the way that the respiratory, the pulmonary system works together with the swallow, and collectively I refer to those as the aerodigestive tract. So breathing disorders, kind of, I don't do like what a pulmonologist would do or what a respiratory therapist would do, but there still are things like respiratory muscle strength training for inspiratory and expiratory muscles. And so that's something, depending on what you're doing it for, that's a big part of what I do and what I recommend.
Do you work closely with the speech therapist?
So that's what I am technically. It's a speech-language pathologist. So, but that's a master's level degree, and then you can get a PhD in ED or an SLPD. And so that's where I went the clinical route and got an SLPD. And so that is, that's professionally what I am as a speech-language pathologist. You just got the doctorate in there.
Right. Now I see, like, just more in depth of what speech therapy is. Do you also come across a lot of paralysis and, facial paralysis is what I mean. Mm-hmm. And patients who have weakness in muscles that are in their jaws, like you mentioned earlier, there's so many nerves, because I come across a lot of Bell's palsy, facial mm-hmm. palsy, facial nerve palsy patients. So I see a lot of drooling from their mouth. So I do come across those things, but there's nothing specific that we do for that. Yeah. We do the face in general as a whole. We do different expressions, mm-hmm. different electrical stimulation, and lots of exercising. But do you see a lot of paralysis patients?
I mean, it depends. So you've got, with what you mentioned with Bell's palsy, which is intrinsically, it's a lower motor neuron issue. So you're thinking the cranial nerves, well, for this case, it's the facial nerve, cranial nerve 7. But if you have a lower motor neuron issue, then it can cause complete facial flaccidity on one side or the other. But with like patients who've had strokes and they've had upper motor neuron damage, you get the same sort of thing, but to a lesser degree. But again, because the etiology is different, the cause is different, you would look at it in a different way. I personally don't, my opinion is that I don't know that there's much that we can do exercise-wise for Bell's palsy, but for some of the things like facial weakness due to an upper motor neuron lesion, that's kind of a different story. You might work into some rehabilitation there that could help with drooling or a number of other things. Vocal cord paralysis, I mean, you can have paresis or paralysis in a number of different places. So if it's affecting swallowing or if it's affecting communicating, then yeah, there's definitely, I would say, potential for me to work with that individual.
Right. What about cervical cord dysfunctions? Like you mentioned, there are cervical nerves that I was not aware about. Like it was so complex. It seems very simple, but that one small system is so complex. Do you come across a lot of cervical cases?
I mean, people who have so if it depends on a few different things. So there are at least two muscles that are involved in the oropharyngeal swallow that come from the cervical spine. C1, the geniohyoid, and oh dear, my mind escapes me for the other one. But anyway, but for C3 through C5, you're dealing with the phrenic nerve going to the diaphragm.
Right.
And so with that, yeah, there's a lot in breath swallow coordination. And so if you have someone with diaphragm issues, with breathing issues, that can be an issue, or even somebody who doesn't get the respiratory support for their motor speech function, yeah, then sure, that it just depends on a lot of different factors. But yeah, cervical injuries definitely can impact swallowing or motor speech.
How do you go about treating?
Good question.
Yeah.
It's tricky. It really depends on what it is. So if we're talking about like somebody has their diaphragm paresis or something like that, or hemidiaphragm paresis or whatever, I think of it in terms of, first, functionally, what is it affecting? And so for this, it would probably affect the speech because it's the respiratory drive. Right. You have to have the respiratory drive to make the vocal cords phonate and vibrate. And so respiratory drive, or actually it's ventilatory drive. Sorry, the term respiration is broad, but that actually refers to gas exchange. But ventilation is just air coming in and out. So if you're talking about the air coming in and out, if you have a diaphragm issue, that's going to affect that potentially, because the diaphragm contracts and it moves down and it causes the lungs to expand. And so if somebody can't get enough air in from the diaphragm, they're going to have reduced support for voicing. They also may have, I don't know, inadequate's the word, but suboptimal ventilatory drive for swallowing as well. And so if that's the case, and if it's having a functional outcome, I would typically look into respiratory muscle strength training, RMST, and could be inspiratory or expiratory muscle strength training, depending on what's going on. And so, I would think if someone had a diaphragm hemiparesis, I would probably go for inspiratory muscle strength training, because the diaphragm is an inspiratory muscle, to help build the contraction with that. But if that, is impacting something in the expiratory drive, then you could also consider EMST. But IMST, inspiratory muscle strength training, would be, one of the first things that comes to mind for that.
What about stroke? Like, for example, if we have a stroke patient who is facing dysphagia, how would you begin with even evaluating the patient?
Well, it depends on a lot of different factors. If you're thinking of somebody with a stroke, I'm going to look into their chart first to get an idea of where the lesion is, how large is the lesion, a little bit of information about their past. Do they have any comorbidities? Do they have COPD? Have they had a stroke prior to this? To really try to get a hypothesis in my mind of what their dysphagia, their swallowing disorder, may be presenting as. Right. And then going to see them, initially interviewing, but a lot of people aren't really that aware of their swallowing issues. But I would try to get a little more information, and then do what's called a clinical swallow evaluation. And mostly what that is it's doing a cranial nerve exam where you're looking at the jaw, the mouth, the face, the soft palate, the voice, and a number of different things, and giving a few trials of food and liquid to see if they're showing any overt signs and symptoms of, or excuse me, signs of aspiration or laryngeal penetration of the vocal cords. So are they coughing after they swallow? The symptoms might be, are they complaining of anything sticking in their throat? Signs, if you palpate here and you feel them, so there's some nuance to this, but I won't go into the nuance. But if you palpate, that's a good indication that somebody is a decent indication that somebody's swallowing. If the larynx moves a certain degree and comes back down, not for sure, but if you feel them like take a sip of water and they're doing that 4 or 5 times, then that's an indication something could be wrong. But I don't have X-ray vision, and so at that point, I would recommend what's called a modified barium swallow study, which is basically an X-ray of the oropharyngeal swallow. And so it's usually in a lateral view. And so you see what's going on in the mouth and in the oropharynx, the nasopharynx, the hypopharynx, and the larynx, so you can see how they're protecting their airway. And so based upon that exam, or you could do an endoscopic exam too, first of all, I want to describe what's happening. Like, okay, are they aspirating? And if they're aspirating, why do I think they're aspirating? Because like I said, there's roughly 30-ish muscles that are working together. And so you want to, as much as you reasonably can, pick out, which one or which group of muscles or which physiological process is not working as it should, to try to specifically target that with rehabilitation, if you can, if there even is an exercise for it. The other thing is trying to think like, well, a lot of people have dysphagia after strokes, and a lot of it improves spontaneously. Right. And so like, if it's not or is unlikely to have a huge functional impact, and by that I mean, is it likely to cause them to get pneumonia, choke, have nutrition or hydration issues, or mess with their quality of life, then I might not do anything. It just depends. Right. But at the same, I guess in the acute phase, you want to do things to manage it, but there are just so many variables involved that it depends on a lot of things. But that's kind of the overall process, getting the overall context of their health, their complaints, their issues, and then doing a thorough examination, typically in that case using X-ray or endoscopy to find out specifically what the pathophysiology is, what's pathological, what's not working right, and go from there.
Right. I didn't know about the barium study and the specific endoscopy for the esophagus, or just the.
It would be the pharynx and the larynx, the throat and the.
Yeah. Right. Yeah. So yeah, it helps. It's like your evaluation, like how do you do a lot of jaw reflex?
What's that?
Do you do a lot of jaw reflex?
Jaw reflex?
Yeah.
No. No, not really.
One thing we do.
Yeah.
As physios, yeah.
Tell me.
As people.
I can't even say I'm even familiar. Can you tell me more about that?
Yeah. So you keep your hand and try hitting it with a hammer.
Oh.
And if the jaw closes, that means I'm not too sure which nerve, because closing of the mouth is controlled by which nerve?
The trigeminal. So cranial nerve 5. Yeah.
Yeah. I was not too sure about 5 or 7. They get me confused all the time.
Well, yeah, because oh no, I'm an idiot. I'm so sorry. Wait, hold on. You're making me doubt myself. No, because facial nerve is 7, and so that's movement of the face and mouth. Sensation is 5, but yeah, right. Trigeminal. I think geminal jaw, the jaw movement is 5. Okay. But yeah, the rest.
Okay. So we're sure it's 5, not 7.
Yeah, it's 5.
Okay. So yeah, if there's closing of mouth, then that means your jaw reflex is intact, and that was the only thing that we studied for our nerve testing for jaw. That's the only thing I can remember. And yeah, we do a lot of facial exercises for Bell's palsy. That's very interesting. I would love to know a little bit more about like the 30 muscle groups and what do you do as in for exercise, because I'm like, okay, let's make them work. Let's make all the muscles work, even if it's in the jaw. Yeah. Let's just get doing biceps and doing push-ups and squats.
Yeah.
Everything.
Yeah, do it all. Well, I mean, like that's one of the issues in our field, though, is there aren't enough treatments that have a really strong evidence base out there. And we're learning more, and I think I really suspect that there's going to be more emerging. I think that we're on the right track, but it's kind of a wake-up call right now. And so anyway, there need to be more exercises out there that are shown to be effective with different processes. And so we're kind of in that limbo right now.
Maybe we can work together and find out more exercises.
There you go. There you go. Yeah, I mean, there's something to figure out for sure.
Do you do a lot of research?
Not in particular. I'm mostly education and clinical practice. I'm interested in research, but as far as me personally, no, not yet, not much.
Yeah, you never know. Research is so vast that it's always open. There's always opportunities. There's always something new coming up out there.
Lots of questions that I would love to research, but that's just the PhD is the research degree more so, and mine's more of a clinical focus. But I still, hope to get into some. We'll see how it goes.
What did you do your PhD in? Like specific research?
At SLPD, not PhD. So PhD is really research heavy. SLPD, I mean, is part of that. I worked on a project to look at norms for residue in the throat using the something called the Yale Pharyngeal Residue Severity Rating Scale. It's more of a descriptive study, but I haven't executed that yet. But that was a part of that degree. But it's kind of a broader degree, less focused into one particular thing than a PhD, but with a lot of emphasis on integration of material into whatever your clinical passion is.
Right.
Yeah.
Oh, that's nice. Interesting. It's very interesting. I'm gonna go and research the barium thing, modified barium.
There you go.
I'm gonna
modified barium study.
For sure. And I love the glowy, shiny X-rays anyways, so I'm gonna just look into.
Yeah. Nice.
Yeah. My next question is, like, this is going on in my mind. When there a lot of patients are on muscle relaxants and painkillers, that a lot of antidepressants, anti-anxiety meds, which slows the whole system, the whole muscle, the whole muscle system down. Does that affect the swallowing and the dysphagia, but to any extent?
Well, I mean, there are medications that can impact swallowing, and that's really another kind of shortcoming in our education is really the emphasis on pharmacology and the impact of it. But the thing that makes me think of more is the influence of aging, so like or multiple medical comorbidities. So people who are on so many medications, they are on medications for certain medical issues, and especially like as you get older, your ability to maintain homeostasis, regulating between inside and outside to keep your body temperature and a number of other different things equal and balanced. Your ability to do that lessens. It's something called homeostenosis. It lessens as you get older. And so in that type of thing, if you get somebody who is ill or they're on some sort of medication like that, it's more likely to impact them in a more significant way than it would someone who's our age. But as far, so that's one thing that comes to mind in particular. But there are advisements for medication for people who have Parkinson's to take, your carbidopa, levodopa an hour before and whatnot. But there's not a lot as far as like, other than putting people to sleep, it's harder to swallow when you're not alert, that come to mind immediately that would, like, in a healthy person, just cause issues to the swallow. But then again, I'm not a medical doctor. An ENT might know a little bit more about that, but at the same time, there's nothing that really jumps out at me in a healthy person off the top of my head.
Right. What about coma patients? Do you do a lot of inpatient coma patients?
So sometimes it depends. So I've worked in acute care, and for anyone who's listening, that's just like what you think when you think of the hospital. You go to the emergency room, and if you're admitted, then you're in acute care. And so depending on setting, maybe. So there is a place where I work in a long-term acute care setting, And there are patients for whom they're in an altered state of alertness. So coma, to me, is not necessarily like binary, like one or the other. But if you look at things like the Glasgow Coma Scale, you know, if you're a 3 out of, I think, 15, then it's, well, maybe more than 15, I'm not sure. But if you're a 3, like that's the lowest you can get. You're basically like as comatose as you can get. Versus like you respond to pain, then your score is a little higher and you're a little better. So yeah, I've used that to kind of assess improvements in consciousness that could perhaps relate to communication and other function. And then of course there's the Ranchos Los Amigos too, which is a little bit more in detail. But yeah, so to depending on where I'm working, potentially, yeah.
Oh. Do you come across a lot of misconceptions in, swallow pathology?
Oh yeah, all the time. Yeah, definitely.
What are a few of them?
Speech pathologists watch people eat. That's what they do. That's a big one. That's an annoying one too. But at the same time, I'm not going to say that there haven't been, I don't want to say bad players, because that implies intention and people, doing something wrong intentionally. But people who have done more of that when they shouldn't be, versus understanding, implementing, if someone's eating or drinking something, the signs and symptoms of dysphagia with the cranial nerve exam. So putting those together and combining that with the history and the medical etiology that and then the instrumental exams like the modified barium swallow or the fees. So yeah, I mean, a main misconception is that it's just a lot simpler than it is, I would say.
Yeah. I can see just by talking to you today that it's not at all simple. It may be small part, small, focus, but it's definitely not simple.
Yeah, there's a lot that goes into it, and the more you learn about it, it's like, oh, the more I didn't realize I didn't know. Like there's a lot to it. It's very fascinating, and the whole, like, sometimes I think we miss out on the impact from like one system to another.
Right.
Looking at things like very broadly. And so, I mean, that's a big part of it too, because your breathing can affect your swallowing can affect your breathing, your brain affects your breathing. And, there's just all this interplay between many things. And if someone's, even your urinary tract can, if somebody is on thickened liquids, which I'm not a huge fan of, they can get dehydrated, or if they have an inefficient swallow, they can get dehydrated and get urinary tract infections. And depending on their age and a number of things, that can mess with their mind, and they can be real loopy. And yeah, it's an onion. There's just so many things to peel away.
Yeah, it makes sense, because I was gonna say this, that it may seem very simple, but you deal with breathing, you deal with digestion, you deal with face, chewing. There's so many things, speech, vocal. So it's a lot more to it. What made you choose speech therapy to begin with?
Oh, I was trying to figure stuff out, and I was kind of on the fence, but then I shadowed at a hospital when they did a modified barium swallow study, and I was like, this is really freaking cool. And so since that, I've kind of been hooked.
Really? This was how long back?
This would have been, oh dear, I don't know. 2010, 2011, maybe 2010-ish, 2011 maybe.
14 years, and you knew that this was your path.
I wouldn't say that, but I knew it excited me. So yeah, I knew I wanted to do it at that time.
What are a few things that, few tips that you would tell everybody who is listening that, okay, avoid this, or maybe have this more? What would you suggest?
Oh man, that's a really good question. I mean, just in general, try not to oversimplify, and, look to be humble about what you know and don't know. Look to others and be respectful of their knowledge base, those who are in other disciplines, and don't be afraid to reach out and collaborate. Like, there's just too much for any one discipline or any one person to know. And so discussion and collaborating with others and admitting vulnerability about what you don't know is incredibly important because it helps your growth, but it also helps your ability to get the information that you need to best help your patients at that particular time.
Right. I keep seeing videos of your podcast. Can you tell me a little bit more about that, the work that you're doing, than being a clinician and a teacher doing so much?
Yeah, sure. So that was something, I mean, I love talking about dysphagia, especially on these podcasts where I can learn from a lot of these people who are just extremely brilliant within their own areas and within their own passion. So it was largely a response to some barriers that I've experienced within dysphagia education from both the side of being a student and the side of being an instructor.
Right.
That there are a lot of things missing because one, for the period of time and just resources to hospitals to do training and that sort of thing too. But research has really brought out some gaps in what we don't know. I can think of 3 studies, at least off the top of my head, that show limitations in the knowledge base that speech pathologists get and come out with upon graduation. And again, not to cast fault. I'm not trying to point fingers and to cast fault because we're a product of our education to such a degree, and our education has gotten so broad that it's kind of like, I'm afraid it's going to implode. And so this was a response to that, to try to bridge these gaps. That's why the podcast, it's called Swallow the Gap, because we're working with patients with swallowing disorders, but there's so many gaps. Yeah. And then you can say swallowing means to consume something. So we're trying to consume these gaps and get conversations started. Because the more people you have talking about it, you know, you get different minds that are bright and more information and just more conversation about something that needs to improve. And also that there are continuing education courses that I'm arranging around that, and it's pointing people, you know, serving to point people toward those continuing educational courses. But a lot of it's a conversation starter. It gets people talking about things that are important. It gets, you know, smart people talking, invested people talking, and it's a resource that I can put out there for people to listen to and don't have to charge for it. You know, hopefully they'll pay for a course later, but you know, if they don't, that's still leaving things better. Yeah, it's still leaving things better than it would have been. And so that's, yeah, Swallow the Gap. If anyone's interested, swallowthegap.com/podcast, or on Apple or whatever works for you, Swallow the Gap. But yeah, the website is either swallowthegap.com, or you can do GAP SLP, like speech language pathologist, gapslp.com.
That's awesome. I love that you gave all the information, and it was perfect. The intention behind it is so pure, and your love for this field, your love for dysphagia is seen. It's seen right now that you really like talking about it, teaching about it, and just learning more. Like you said, you know, we're all trying to learn new every day, every time that we're meeting someone. And I saw a few clips. You were on the podcast with so many people out there, and it was really nice. It was good, and you need people to talk about who are experts. Like I always keep saying, who are experts. You need people out there to just have a conversation with them and discuss more about the field that you both love. So I'm glad. What are your plans for the upcoming year with the podcast and the teaching?
Really good question. Right now, I'm teaching at 2 places. I'm teaching an aphasia and cognitive communication disorders class at the University of Hawai'i. But I was full-time for a while at a university called Rocky Mountain University of Health Professions. It's a small, just healthcare-focused school in Utah. And they have a phenomenal speech pathology program. And I'm teaching their advanced dysphagia course right now. I don't know that there's anything I'll be working with them for over the summer, not that I've heard of yet, but for Hawaii, I'll probably teach their motor speech disorders course. And so like for the podcast, I mean, I'm going to organize some continuing education events. That's the plan. But for the podcast, it's a lot of work, and it's like, you know, it's work that I'm not really, at least yet, like making anything from. It's like volunteer work. And so like, I love it. But at the same time, I'm like, also like it's very exhausting. And so the idea was to come in and maybe do season 1 with 15 episodes and then take a break and then do a season 2, because it would be a stinking marathon to just do this every week. I don't know if I can handle it, but I don't want to, I don't want to lose the momentum. So we'll see.
But I love the idea. It gives a good finishing, a good definition to your first season, and the layout. Because I'm looking for something like that. Actually, it's brilliant, but I just winged it.
Yeah.
I was like, let's talk about health, and it just started. But yeah, I like the flow of events, and the thing, since I'm the only one who's organizing and who's conducting, I'm the resource person, so I can take it at my own pace, at my own, But I love a good schedule. I'm willing and I'm waiting for that. So maybe the season idea. So I might take that from you.
What's that? Oh, taking a break to do the season 1. Yeah.
Probably my brother will be visiting me. He's actually coming next week, which is why I wanted to get a lot of work done this week. And he'll be here for a month and a half, just visiting.
Nice.
So I'll be showing him around. It's his first time in New York, so I'll be showing him. We'll be doing the New York things, and it'll be very exciting. So I'm excited. So I'll be taking a break probably.
Yeah. No, that sounds great. Well, enjoy. Yeah, you got to enjoy your time with them. I work to live. I don't live to work, but it's easy to get that kind of miscalibrated, the reason why you're doing it.
Definitely. Is there any last words that you would like to tell our audience out there?
I don't, I can always mention the podcast again. It would be a huge favor for anyone just to check it out.
Yeah.
gaplp.com/podcast, Swallow the Gap podcast. Or if you wouldn't be interested because it's not your thing or whatever, just sharing it with speech pathologists at your work or whatever. That would mean the world.
Yeah.
But no, I hope people feel welcome to reach out on Instagram anytime. Follow me if they're not. And I guess that's about it. But yeah, I appreciate you having me on. I appreciate what you're doing.
Thank you. I love how I put you on the spot for all the non-SWOT related questions.
I'll give it a shot.
Yeah, I love that.
Might not turn out well, but we'll see. Cool.
But thank you so much for speaking with me today. It was lovely. I learned so much, and you definitely left a student with so much more knowledge today. So thank you for that.
Cool. Yeah. No, you're welcome, and thanks for organizing this. I appreciate it.
Definitely. I'll see you soon. Very maybe we have more collaborations. We hop in on a podcast soon. But yeah.
Cool. We'll have a good rest of your day.
You too.
We'll or I guess rest of your night. It's late there.
Yeah. Bye-bye. Good night.
See ya.
Thank you for listening to our talk about health. You can follow me on Instagram at bhavna.devnani, on Facebook at bhavna devnani, and we'll leave all the information in the description below. Thank you.